everyone, welcome to my channel. This is the part 2 of clinical anatomy of thorax. The link for the part 1 is given below in the description. So in this video we are starting with the heart, pericardium and heart. So the first clinical correlation is with the pericardium, pericarditis and cardiac tamponade. The inflammation of the serous pericardium is called pericarditis, and that causes the accumulation of the serous fluid in the pericardial cavity, the pericardial effusion. So as you can see here, this is the normal pericardium and this is the inflamed pericardium, where the serous fluid can accumulate and cause the effusion. The excessive accumulation of the serous fluid in the pericardial cavity may compress the thin-walled atria and interfere with the filling of the heart during diastole, and consequently the cardiac output is diminished. And this condition is your tamponade. So here you can see the fluid filling is compressing the components present within the pericardial sac. Moving on to the next, that is pericardiocentesis and pericardial rub. Excessive pericardial fluid can be aspirated from the pericardial cavity by two routes. One is sternal approach and another is subxiphoid approach. In sternal approach, the needle is inserted through the left fifth or sixth intercostal space immediately adjacent to the sternum. In subxiphoid approach, the needle is inserted in the left costoxiphoid angle and passed in an upward and backward direction at an angle of 45 degrees to the skin. This is subxiphoid, you can see. The angle here should have been 45. Yes. Then there is pericardial rub, friction rub. The roughening of the parietal and visceral layers of the serous pericardium by inflammatory exudate can cause friction between the two layers called pericardial friction rub, just like the pleural rub that we have seen in the last video. And this pericardial friction rub can be felt on palpation and heard through the stethoscope. Moving on to an important clinical correlation in heart, that is apex beat. Apex beat is the outermost and lowermost thrust of the cardiac contraction during ventricular systole, felt on the front of the chest, or it is the point of the maximum cardiac impulse. Normally, the apex beat is felt as a light tap in the left fifth intercostal space in the mid-clavicular line. But in infants and in children up to age 7 years of age, the heart is positioned more horizontally, so that the apex of the heart lies in the third or fourth left intercostal space, and consequently the apex beat is felt in the third or fourth intercostal space just lateral to the mid-clavicular line. Normally, the apex of the heart is on the left side and the apex beat is felt on the left side. But sometimes the heart is malpositioned with the apex on the right side, and this condition is called dextrocardia. Now with the heart, there could be complete reversal of the thoracic and abdominal viscera. And this condition is called as situs inversus. Moving on to the radiograph, chest radiograph. Here you can see the PA view of the chest. So the cardiac shadow is visible clearly in this X-ray. Here you can see few landmarks. First we are seeing here the aortic knuckle. Then we can see the left hilum and pulmonary artery. Then we can see Carina. When we can see right hilum and pulmonary artery, right atrium, left ventricle. And this is your cardiac shadow. So overall we can say the left border of the cardiac shadow from above downward is formed by aortic arch, pulmonary trunk, left auricle and left ventricle. The right border from above downward is formed by SVC and right atrium That's it. Moving on next to murmurs. The abnormal heart sounds are called murmurs. They are produced due to regurgitation of the blood heard when the valves are either stenosed or when the valves are not completely closed, leading to regurgitation. Now in aortic and pulmonary stenosis, the murmur is heard during systole, and in insufficiency of these valves, they are heard during diastole. In stenosis of mitral and tricuspid valves, the murmurs are heard during diastole and in their insufficiency during systole. Then we will see mitral and tricuspid stenosis. Stenosis means narrowing of the orifice. So mitral stenosis is narrowing of the mitral orifice. It is most common in young age. Usually there is a history of rheumatic fever in the childhood in these cases. This leads to rise in the left atrial pressure and enlargement of the left atrium, which may press on the esophagus. Clinically, the features of mitral stenosis will be shortness of breath, that is dyspnea, dysphagia, and hoarseness of voice, Ortner syndrome. So in this diagram, you can see in diastole, we are seeing normal valve mechanism. And in case of mitral valve stenosis, there is narrowing of the mitral orifice and the blood moving into the ventricle is less. You can see here stenosed valve. Aortic and pulmonary stenosis. Aortic stenosis, the accumulation of fluid in the left ventricle causes its dilatation and hypertrophy. There is low cardiac output, which may manifest as syncope on exertion. Syncope is fainting on exertion. So here, as you can see, there is this aortic stenosis. So there is restricted blood flow. When you can see here normal blood flow, there is normal aortic valve. And in case of pulmonary stenosis, it is almost always congenital, usually a part of Fallot's tetralogy, and it leads to hypertrophy of right ventricle. So here, as you can see, the blood goes from right ventricle to the pulmonary trunk and then to the lungs. And there is this part, pulmonary stenosis occurring here. There is a narrow area, and because of this, the blood is accumulated into the right ventricle. Now the right ventricle will try to push the blood into the pulmonary trunk and hence will become hypertrophied. Next is the conducting system defects. The defect or damage of the conducting system causes cardiac arrhythmias. The SA node is the spontaneous source of generation of cardiac impulses. The AV node picks up these impulses from atria and sends them to the ventricles through the AV bundle, and the only means through which impulses can spread from atria to ventricles. If the AV bundle fails to conduct normal impulses, there occurs alteration in the rhythmic contraction of the ventricles, and this is arrhythmias. If a complete bundle block occurs, there is complete dissociation in the rate of contraction of atria and ventricular. The most common cause of defective conduction from AV bundle is atherosclerosis of the coronary arteries that lead to diminished blood supply to the conducting system. Now there is a difference between tachycardia, bradycardia and arrhythmia. Tachycardia is rapid regular pulse. Bradycardia is slow regular pulse, whereas incomplete irregular pulse is arrhythmias. And that is the conducting system defect. Moving on to the clinical correlation of the arterial supply of the heart. Angina pectoris. If the coronary arteries are narrowed, the blood supply to the cardiac muscle is reduced. As a result, on exertion, the patient feels moderately severe pain in the region of the left precordium that may last as long as 20 minutes. The pain is often referred to left shoulder and medial side of the arm and forearm. But in angina pectoris, Pain occurs on exertion and relieved by rest. This is because the coronary arteries are so narrowed that the ischemia of the cardiac muscle occurs only on exertion. So here you can see the insufficient blood flow to the heart muscle from narrowing of the coronary arteries. There is a plaque in the coronary arteries. Atherosclerosis can cause angina pectoris. Again, coming in the second year, you can study types of different angina. Even in physiology, there will be stable, unstable, and vasospastic or the variant angina. Moving on, next is myocardial infarction. A sudden block of one of the larger branches of either coronary artery usually leads to the myocardial ischemia, followed by the myocardial necrosis or myocardial infarction. The part of the heart suffering from MI stops functioning and often causes death. This condition is termed heart attack or coronary attack. This is obviously different from heart failure. Now, the clinical features of MI are a sensation of pressure or sinking and pain in the chest that lasts longer than 30 minutes. Angina pectoris pain on exertion occurs and it lasts for 20 minutes. But in MI, the pain lasts longer than 30 minutes. Nausea or vomiting, sweating, shortness of breath and tachycardia are other clinical features of MI. Then the pain radiates to the medial side of the arm, forearm and the hand, and sometimes it may be referred to the jaw or neck. Then we have coronary angiography. The coronary angiography is a radiological procedure to visualize the coronary arteries after injecting contrast medium in the lumen. Coronary angiography is useful in localizing the sites of the blocks in the coronary arteries. So here you can see this is normal coronary arteries on the left side. These are normal coronary arteries in the right side. In the right side, this one is your right coronary artery and this one is your posterior interventricular branch. Then here you can see in this left side, you can see the anterior interventricular branch and the circumflex branch. And there is this left marginal branch also. Moving on to coronary bypass surgery. You have heard many times the word bypass. The coronary bypass surgery has become common in recent times in patients with unstable or severe angina due to obstruction of the coronary artery. A segment of a vein or an artery is connected to the ascending aorta and then to the coronary artery distal to the obstruction. So here you can see this is connected to aorta and then to this coronary distal from this obstruction. A coronary bypass graft shunts blood from the aorta to the coronary artery distal to the blockage to increase the circulation. Now the great saphenous vein is commonly used for grafting because it is easily dissected. The diameter is equal to or greater than that of the coronary artery and it provides lengthy portion with minimum branching or valves. So of course you have to invert it and put it there so that valves won't bother. Another graft used is of internal mammary artery or internal thoracic artery. This is because this graft lasts long and it is histologically less prone to atherosclerosis. Moving on to coronary angioplasty. In this procedure, the cardiologist pass a stent, a small catheter with a small inflatable balloon attached to its tip, into this obstructed coronary artery, and as the catheter reaches the obstruction, the balloon is inflated. As a result, an atherosclerotic plaque is flattened against the vessel wall and the vessel is stretched to increase the lumen. Consequently, the blood flow is increased. Sometimes transluminal instruments with rotating blades or lasers are used to cut the clot. After the artery is dilated, an intravascular stent is introduced to maintain the dilation. Obstruction of SVC, superior vena cava, and development of collateral pathways. Now, SVC may be obstructed or compressed at two sides. With respect to the azygos vein, it can be above the opening of the azygos vein, that is in the superior mediastinum, or below the opening of the azygos vein, that is in the middle mediastinum. If the SVC is obstructed above the opening of the azygos vein, the venous blood from the upper half of the body is shunted to the right atrium through the azygos vein. The main collateral pathway are provided by superior intercostal veins, and the superficial veins of the chest wall do not receive sufficient blood to cause their prominence. If at all they become prominent, the prominence is limited by the costal margin only. If the SVC is obstructed below the opening of the azygos vein, that is in middle mediastinum, the venous blood from the upper half of the body is returned to the right atrium through the inferior vena cava through the collateral pathways formed between the tributaries of superior and inferior vena cava, that is caval-caval shunt. Clinically, under this condition, a subcutaneous anastomotic channel between the superficial epigastric vein and the lateral thoracic vein, that is thoracoepigastric vein, is seen on the anterior aspect of the thoracoabdominal wall. Next is aneurysm of aorta. Now there can be aneurysm of the ascending aorta or the aneurysm of the aortic arch or descending aneurysm. Aneurysm is nothing but a dilatation or a ballooned and weakened area of the artery. Now the aneurysm of the ascending aorta occurs at the bulb of the ascending aorta. The bulb of the aorta is the dilatation in the right wall of the ascending aorta that is subjected to constant thrust of the forceful blood current ejected from the left ventricle. It may compress the right atrium, SVC, or the right principal bronchus. Its rupture, which is a serious complication, can lead to the accumulation of blood in the pericardial cavity, and that is hemopericardium, and even effusion, that is pericardial effusion. Next is the aneurysm of arch of aorta. It is the localized dilatation of the arch and causes the compression of the neighboring structures in the superior mediastinum, which produces mediastinal syndrome. The characteristic clinical sign under this condition is tracheal tug, which is the feeling of tugging sensation in the suprasternal notch because of the mediastinal syndrome. Then there is dissecting aneurysm. Under this condition, the blood from the aortic lumen enters into its wall through a tear in the tunica intima, creating a channel of blood in the tunica media that leads to dilatation of the aorta. Here you can see the blood in the wall of artery. Clinically, it presents as pain in the back due to the compression of intercostal nerves. Occasionally, the aorta may rupture into the left pleural cavity. Then there is another clinical correlation of aorta. There is coarctation of aorta. It is congenital narrowing of the arch of aorta just proximal or just distal to the entrance of the ductus arteriosus. The collateral circulation develops between the branches of subclavian artery and those of the descending aorta, namely anastomosis between anterior and posterior intercostal arteries. Now the clinical features. There is a difference in BP of the upper and lower limbs. There is high BP in upper limbs and low unrecordable BP in the lower limbs. There is notching of the lower borders of the ribs due to the dilatation of the engorged posterior intercostal arteries, and there is pulsating scapulae. Next is patent ductus arteriosus. In fetal life, the pulmonary artery is connected to the arch of aorta, just distal to the origin of the left subclavian artery, by a short wide channel called the ductus arteriosus. Normally after birth, it closes functionally within a week and anatomically within 4 to 12 weeks. The obliterated ductus arteriosus is called ligamentum arteriosum. Non-obliterated ductus arteriosus is called patent ductus arteriosus. And why is it not good? Because of course you don't want your oxygenated and deoxygenated blood to be mixed again. Next we are moving on to the trachea. First we will see the palpation of trachea and tracheal shadow in X-ray. Clinically, trachea is palpated in suprasternal notch. Normally it is median in position, but if there is mediastinal shift, then trachea can shift to left or right side. Then there is tracheal shadow in the X-ray. As you can see here, this is the tracheal shadow. It is seen as a vertical translucent shadow in front of the cervicothoracic spine. The translucency is due to the presence of air in the tracheal lumen. Now this is carina. The importance of carina. Carina is actually keel-like median ridge in the lumen at the bifurcation of the trachea. The lowest tracheal ring at the bifurcation of trachea is thick in its central part. From the lower margin of this thick central part of keel-shaped process projects downward and backward between the right and left principal bronchi. Now there are functional and pathological importance. Before seeing that, let me show you here in the diagram. This is your ridge, that is carina of the trachea, and there is bifurcation of trachea into the right bronchus and left bronchus. Here this is the bronchoscopic image. This is your ridge, that is your carina, and you can see the bifurcation into right and left bronchi. This is a bronchoscopy of a tracheal bifurcation where you can see a tracheobronchial tumor. And this bronchoscopy is actually done to see if there is any tumor or anything obstructing in this tracheobronchial tree. And as you can see here, the ridge is a bit shaken up to the other side and there is this mass present here. So let's see the importance. Functional importance. The mucosa of the trachea over the carina is the most sensitive, and the cough reflex is usually initiated here, which helps to clear the sputum. Pathological significance. It is visible as a sharp sagittal ridge at the tracheal bifurcation during bronchoscopy, hence serves as a useful landmark. It is located about 25 cm from the incisor teeth and 30 cm from the nostrils. If the tracheobronchial lymph nodes in the angle between the main bronchi or principal bronchi are enlarged due to the spread of the bronchiogenic carcinoma, the carina become distorted and flattened. Next is the importance of mucus secretion in the tracheal lumen. Mucus secretion helps to trap the inhaled foreign bodies, and solid mucus is then expelled during coughing. The cilia of the lining epithelium of the mucous membrane also beat upward, pushing the mucus upward. The fibroelastic ligament prevents overdistension of the tracheal lumen, while the trachealis muscle reduces the diameter or contraction during coughing that involves increased velocity of expired air required for cleaning the air passage. Moving on to the clinical correlation of esophagus, there is esophageal constrictions. The clinical significance of this esophageal constriction are due to following reasons. These are the sites where swallowed foreign bodies are most likely to be lodged or stuck in the esophagus. These are the sites where strictures develop at the ingestion of corrosive substances. These sites have predilection for the carcinoma of the esophagus, and these are the sites through which it may be difficult to pass esophagoscope or gastric tube. So in this diagram you can see the site of constriction. The first constriction that at the pharyngoesophageal junction, second constriction by arch of aorta, third constriction by left principal bronchus, and fourth constriction is by right cruise of the diaphragm. Next is another clinical correlation of esophagus, that is esophageal varices. The lower end of the esophagus is one of the important sites of portocaval anastomosis. In portal hypertension, for example, due to liver cirrhosis, there is back pressure in portal circulation. As a result, the collateral channels of the portocaval anastomosis not only open up but become dilated and tortuous to form esophageal varices. And the ruptured esophageal varices caused hematemesis. Hematemesis is vomiting of blood. There are these terms like hematemesis is vomiting of blood, hemoptysis is blood-stained sputum. Next is barium swallow examination of esophagus. Now it is performed to detect the enlargement of the left atrium due to mitral stenosis or the esophageal strictures and carcinoma and Achalasia cardia. What is Achalasia cardia? Achalasia cardia is a clinical condition in which the sphincter at the lower end of the esophagus fails to relax when the food is swallowed. As a result, the food accumulates in the esophagus and its regurgitation occurs. This condition occurs probably due to congenital absence of the ganglion cells in the myenteric plexus of nerves in the esophageal walls. So in the radiographic barium swallow examination, the esophagus have a very characteristic appearance. There is this bird's beak or rat tail appearance in case of Achalasia cardia. Next is tracheoesophageal fistula. It is the most common congenital anomaly of the esophagus that occurs due to failure of the separation of the lumen of the tracheal tube from that of the esophagus by laryngotracheal septum. In the most common type of tracheoesophageal fistula, the upper esophagus ends blindly and the lower esophagus communicates with the trachea at the level of T4 vertebra. So clinically, tracheoesophageal fistula presents as hydroamnios because the fetus is unable to swallow amniotic fluid. Then stomach is distended with air. The infant vomit every feed given or make a cough of bile. The fistula must be closed surgically to avoid the passage of the swallowed liquids into the lungs. Next is the carcinoma of the lower third of esophagus. Now this carcinoma in esophagus most commonly occurs in its lower 1/3 portion. So in this diagram you can see the squamous cell carcinoma, which is typically found in upper and middle sections of esophagus, but in case of Barrett esophagus there is this adenocarcinoma. You will study this in more detail when you study pathology, when you study metaplasia there next year in the second year. And then we move on to the last, that is dysphagia and esophagoscopy. Dysphagia is difficulty in swallowing. It occurs due to compression of esophagus from outside by aortic aneurysm, enlargement of lymph nodes, abnormal right subclavian artery, etc. And also by, let's say, narrowing of the lumen due to stricture or carcinoma. Esophagoscopy is performed to visualize the interior of the esophagoscope. While passing the esophagoscope, the sites of normal constriction should be kept in mind because these are the sites where it could be difficult to pass the esophagoscope. So this is it for clinical anatomy of thorax. Thank you.